Okay, so good afternoon to people in Ottawa and good morning to people in Vancouver. Welcome to the first ever EHSRB NCCH joint conference. And thanks to you guys in Vancouver for hosting the webinar. So we're already a little late, so I'll let Mark introduce today's speaker. Thanks.
Merci, Guillaume. Hi, everyone. It's my pleasure. Dr. Richard Kwok, thank you so much for having accepted our invitation. Richard Kwok, PhD, is Acting Chief of Staff in the Epidemiology branch at NIEH, and is the lead associate investigator for the Gulf study. This is on the potential health effect of cleanup workers, volunteers, and community members from the Deepwater Horizon disaster. Dr. Kwok specializes in the environmental causes of a range from the phone to be on mute, please. And the pervasive nature of the environment and disease etiology has allowed him to work on a number of different projects with domestic and international collaborators from federal, academic, and industry sector. His work has included research into air and water pollution, and non-ionizing UV radiation exposures, with outcomes including cardiovascular, respiratory, reproductive, and cancer health outcomes. Dr. Kwok received his BSPH in Environmental Health Science and his MSPH and PhD in Epidemiology from the University of North Carolina at Chapel Hill. Dr. Kwok, over to you.
Thanks again for the invite to come and give a talk about some of the lessons learned that we've had with the third echo, or okay. Yeah, I have this mic here. Okay, is that okay? Is that better? Is that better? Can we mute the lines, or should I shut this off, or how? I don't know.
20.
Can folks online hear me? Yes? No? Everyone's muted, so okay. Again, this is a technology thing. This may be the last webinar you guys give, but we'll see how it goes. Anyways, just a little bit of history about NIEHS and the institute that I'm with. We are part of the National Institutes of Health, which is the primary medical research arm of the federal government of the United States. But we are the only one that is located outside of the Bethesda, DC area. There are a wide variety of programs that the NIH supports for our mission on studying environmental health. So there's intramural laboratories, which means that we have internal researchers within our organization that study different health outcomes. We also provide extramural funding to academic centers and programs both around the country and around the world. There's also we focus on disease prevention. We have a clinical research program. We also host an actual toxicology program, and we have a strong public health focus. So the goal of today's meeting is to talk about some of the lessons learned from the Deepwater Horizon. So the Deepwater Horizon disaster was happened in April of 2010 in the Gulf of Mexico, and it was the Deepwater Horizon is the name of a drilling rig that was leased to BP, and I don't know why this keeps popping up. And in that explosion, killed.
Sorry, Richard, to interrupt you. It's actually the audio is very faint. Could you move forward to the microphone, please?
Yes. Is that better?
Yes.
Okay. Maybe I'll sit down. So it's like, okay, here we go. It's like, yeah, everyone in the room is very, very patient. So thank you so much for these technical difficulties. So the Deepwater Horizon led to the largest maritime oil spill in United States history. Over 200 million gallons of crude oil was leaked into the Gulf of Mexico and affected a shoreline from the state of Louisiana to the state of Texas. So over 1,000 miles of shoreline were impacted. It killed 11 workers, 17 injured, 98 survivors. But you can see that there was a enormous cleanup effort. Over 130,000 individuals were involved in trying to clean up the oil. And you can see some pictures here of folks pulling boom out of the water. He looks very happy doing that. There are they boomed, that they try to collect the oil, the crude oil on the water using some skimming, and this is a fishing boat that is pulling these booms and trying to pool together the oil enough to light it on fire and burn off a lot of the crude oil, so causing a lot of particulate matter exposures and also NIEH exposures. And then also along the shorelines, you can see teams of individuals here trying to mop up and then pick up and sift through all the sand and all the oil that has washed ashore. So there's a lot of questions in terms of what safety procedures were needed for these response and cleanup workers, and there's a range of community concerns of whether or not these the oil and the dispersants that were used as part of the cleanup was impacting human health. So as part of the Gulf oil spill, there was a rapid public health responses. There was acute symptom surveillance. So a lot of sentinel hospitals, workplace reports, poison control centers were involved. And also focused surveys on specific populations, looking at the occupational health and safety group looked at some of the workers using health hazard evaluations. Our Centers for Disease Control used the Casper model, and some community groups conducted some surveys, for instance, the Louisiana Bucket Brigade. However, these acute responses were not designed to understand any longer-term physical and mental health impacts in the community. Apologize for this thing keeps popping up. I don't know why. So as part of the NIH response, we tried to be as collaborative as possible and do a multi-themed, a multi-pronged approach to try to investigate whether or not there are any potential short or long-term health effects from the Deepwater Horizon. So within our intramural program, which is where I was based at the time, we started the Gulf study, which looked at the human health effects from volunteers. We had the worker training program, train the workers on health and safety at the time. Our extramural group funded 4 academic centers and 45 community organizations to look at health impacts and community resiliency within the Gulf region. And also our toxicology program was involved with some of the models looking at dispersants and cleanup methods, whether or not there's any toxicological concerns within the oil. But the issue was that, so I'm going to focus mainly on the Gulf study, that we weren't able to, we enrolled over 32,000 participants, but we didn't start enrollment until March of 2011, which was 11 months after the fact. The cleanup pretty much had finished by then, and so much of the opportunity to measure exposures at the time were missed. Some of the challenges that we experienced as we launched the Gulf study is that the study populations, there was a mixture of workers and volunteers on site. NIEH conducted a rostering campaign, but then also there's multiple lists of workers, from instance, from BP, the National Guard, the Coast Guard, all had workers, community volunteers had wandered onto the sites to help try to clean up their backyards and communities. And so it was really nebulous in terms of identifying who was involved. And so as an epidemiologist by training, so one of the basic premises of doing a epidemiologic study is this person, place, time. Who was involved, what's the population at risk, when did it occur? And it's very difficult to identify if you don't really know who it is. Also, there's a lot of study development processes, our institutional review board, the Office of Management and Budget, and there's a lot of privacy concerns with the certificates of confidentiality, and how to best involve studying workers while protecting these institutional confidentiality issues. There's also not a lot of data for baseline data on these populations, so it was only available for a small fraction of the cohort in terms of what their baseline health status was or any baseline risk involved. And so, the Coast Guard had some data, but the Coast Guard was just a tiny fraction of who was involved. And also exposure reconstruction. Multiple databases had to be integrated. The available data was difficult to use and not really designed to be used as an exposure assessment for a research epidemiologic study. And so there was a lot of difficulty in trying to determine what individuals specifically were exposed to. And then finally, the timeliness of extramural awards and initiation studies. Like I mentioned, we intramurally weren't able to get off the ground until about 11 months afterwards, but for the extramural community, the academic centers, the community partners, they didn't get on the field until 2 years after the fact. And so now you're going 2 years into a community, 2 years after the event occurred, and into a community and saying, what happened? You know, who was there? What were you exposed to? All based on questionnaires. And so there's a lot of it's kind of subject to a fallible human memory and very subjective in terms of what exactly occurred. So, hello? Okay. The leaders within the Health and Human Services, so Francis Collins is the director of the National Institutes of Health, Tom Frieden for director of CDC, Nikki Laurie is the Assistant Secretary for Preparedness and Response, wrote an article in the New England Journal of Medicine in 2013 saying that research really should be part of the public health emergency response. You know, the goal of these response communities is that, you know, really try to protect public health, but they're doing a disservice without gathering the knowledge that is generated from these well-designed studies that can inform public health, inform these key decision makers in the midst of the response as they're responding to these events, what the public health hazards are, but then also after the event has occurred in the recovery phase, you know, informing any longitudinal changes and things that the key decision makers need to be aware of for chronic health effects that they may occur in these communities that have been impacted. So every disaster presents new issues and uncertainties, but research is really vital in terms of just providing key information to the decision makers in terms of what the response and recovery efforts are needed, and also to inform the future events, because certainly this is not going to be the last oil spill, it's not going to be the last flooding event, it's not going to be the last hurricane or earthquake or wildfire that occurs, and you know so under the disaster umbrella can cover a lot of different scenarios that research can provide timely information, both in the midst of the response efforts itself, but then also in the recovery efforts to try to help these communities get back on their feet and afterwards. So there really is a need for time-critical research. You know, is it safe? Did our efforts help? You know, are there any physical or mental health impacts, both acute and chronic? And we know that a lot of the mental health impacts in terms of depression, PTSD, can lead to physical health outcomes in terms of cardiovascular outcomes, in terms of respiratory outcomes. Are the medical treatments that were provided, are they safe? Are they effective? Maybe you're using some, drugs that weren't properly haven't gone through all of the testing and approval process yet. You're using them off-label. How effective are these? Any risk for exposures and contamination, both in the short term to the responders, but then also long term in the communities after the response community has left. And then also looking at how effective the decontamination and cleanup processes are, and then potential risk factors for recovery and resiliency. Certain communities may be more vulnerable because of some environmental justice or exposure scenario issues. They may be hit by cumulative repeated flooding events or repeated, you know, we know like in the Gulf Coast region of the United States, they get hit with a lot of different hurricanes over the years, and a lot of people have been impacted. And so what's the impact of cumulative traumas over time? And especially looking at vulnerable subpopulations like pregnant women and children, lactating mothers, the elderly, and those with pre-existing conditions, and communities naturally with higher exposures. So despite its importance, disaster research is typically, like I mentioned, delayed or missed. There's really no formal way to coordinate the research. There's a lot of difficulty in terms of trying to fund the research. And there's a whole host of challenges that are people haven't overcome in terms of lack of ready-to-go research. So there's a lot of opportunity missed in these disasters, like for the H1N1 flu virus. There are a lot of IRB issues, so no treatment no research on the treatment was done. For the Deepwater Horizon, like I mentioned, 11 months to start. Hurricane Sandy, 11 months. The Zika response was 4 months. So it was a little better, but we weren't out in the field in terms of collecting information at the time of the exposure to properly inform future events. So the DR2, the NIH Disaster Research and Response, or DR2 program, is trying to identify these data gaps and research priorities and try to improve the processes. You know, get the people into the room, talking to each other, understanding what each capabilities are, what people's priorities are, what they're looking for, and trying to engage the different communities, academia, agencies, workers, the community groups before a disaster occurs. Now, we don't know when or where disaster will hit, but we know it will happen. And so how can we be better prepared and to help inform both the response efforts as it happens or shortly thereafter, and then as they move forward in terms of the recovery efforts, trying to integrate the research community into the planning and emergency response system. So we're working with the Incident Command, the national response plans within the United States to try to be embedded in, so that when we get called out for a federal response, that then we're there on the ground with the incident commanders, so that we're able to provide timely, relevant information. And this, and folks need to see that this is not, you know, research per se, but this is just information for the decision makers to make, so that they can provide more data that they can use to make these key decisions to try to protect public health, and really try to provide mechanisms for support through increases in grants and in our environmental health centers that are located throughout the country. This was a pilot project that was started in 2014, and so now we're in our 5th year, and we're starting to see some results, which I'll talk about a little bit later. So we try to integrate the researcher and stakeholder engagement, and one of the methods of trying to do that is training and education, and trying to integrate ourselves into these natural response plans, but then also use the DR2 models, like try to gather the data collection tools, the protocols, and adapt them to site-specific health and safety issues that may be of concern in the local communities. And so what we've done is conduct these training scenarios with partners that have, the local partners that have identified different scenarios of concern within the local communities. So we went to Los Angeles in 2014, Houston in 2015, Boston, and then earlier this year in Tucson. And we brought together participants from both the federal, the state, the local level of government, but then also academia, community groups, industry, healthcare providers, and get them all into a room together to talk about their priorities, their needs, what they're looking for if in a disaster response scenario, and kind of work through the different issues and identifying gaps and opportunities for collaboration, and to try to move together, so that in the worst time to do a study is when studying disasters is in the midst of a disaster. You can't. The first responders are very busy. They have other priorities in terms of trying to protect immediate life and safety issues. So the last thing in their mind is going to be collecting research information or data for an academic group or a researcher to come in and say, to study these health effects. And so a lot of times it's just kind of preparing them in advance, doing the necessary groundwork, making the introductions to the different communities in advance, so that they're aware of what your needs are, and if they're already going to collect that information, why don't they collect it in this fashion, so that then it can be used in a format for research purposes versus just ad hoc, scattershot thing that a lot of the information they collect just basically gets thrown away, and there's no opportunity to learn from these events down the road. So the DR2 has created a repository and has partnered with the National Library of Medicine in the US to create this website where we collect a lot of the different tools and resources, protocols, questionnaires, environmental and occupational modules for samples and data collection, quality of life issues, and really try to centralize a lot of the platforms that are used in these different disaster scenarios. Like, we know in a hurricane scenario that there's going to be flooding, there's going to be mold issues, there's going to be some respiratory health effect issues, and so gathering some of these questionnaires to look at, we know in a wildfire there's going to be a lot of respiratory issues, there's going to be a lot of these health effects that are going to be coming up. Is there a way to collect that information to gather information, so to identify populations at risk, and then survey these individuals to see what comes up, to identify any hazards that need to be addressed immediately in the short term, but then also chronically in the long term that may show up, that there may be some residual exposures, things in the sediment or in the surrounding communities that may not have been decontaminated or outside of the purview of immediate response efforts, to try to address those points. We also are hosting these rapid acquisition disaster data plans. And so these are a menu of standardized instruments that are pre-reviewed by the NIEH IRB. So these are set protocols that have already been looked at by our IRB to say, okay, you have all this entire suite of scenarios in a disaster. Certainly, you're not going to use every one of them in a disaster, but we looked at them. They look okay, but we want to see the final product when you go into a community of who you're looking at, what specifically are you going to do. And so this is just like a general guidance so that you can take something off the shelf, customize it to what you need, and then be able to deploy it in a matter of days or hours instead of months or years that it may typically take to design an epidemiologic study or a toxicological study to look at some of these events. And so some of the grantees like the University of Texas, University of Iowa, Oregon State have kind of furthered that and taking things and adapted it to their IRBs, run the rapid protocol by their own IRBs and say, okay, the National Institute of Environmental Health Sciences has done this, but then can we adapt it here in Texas? Here's still the broader scenario, but then we think that wildfires are our biggest concern. Flooding is our biggest concern, and so adapt it to these modules so that if a flooding event occurs, tomorrow or the next day, that we're able to kind of get into the ground and start collecting data that may be helpful to inform the first responders, but then also to our research communities and in the communities that are impacted themselves. So we also work with the IRB to try to train the members and the local IRBs to what are the recommendations and best practices for IRB review. Joan Packingham is leading this effort and published an article in the Environmental Health Perspectives in 2017. And then in earlier in Tucson at the University of Arizona, we held a workshop to walk through what the IRB concerns are, in these tabletop exercise, and in a model of like, what would you be concerned of? What would you be looking at? These are the communities that we would be most impacted and then what their concerns are, and then go through that checklist, identifying any gaps and needs that maybe need to be addressed through protocols or policies that need to be put in place. So I just wanted to play this video, which was a summary of the Houston 2015 workshop. So it's going to be a few minutes.
Following many disasters, there are a variety of research questions and uncertainties. Many of these questions surround health and safety issues related to environmental exposure. To improve our ability to explore these questions, the National Institutes of Health began the Disaster Research Response Project, known as DR2. The project aims to develop research tools, protocols, and training materials to enable researchers to safely perform timely environmental health studies. As part of these efforts, the DR2 project held its second tabletop exercise at the University of Texas Health Science Center in Houston, Texas in February 2015. The exercise was conducted to explore how participants can collect important health information to support response, recovery.
I'm gonna put it on speaker now.
common gaps in their capabilities. Participants also discussed ways to better coordinate future disaster research efforts.
Timely research is absolutely critical to prevent injury and illness and to support recovery. I think if we don't do research when we have a major disaster, we put ourselves at risk for the next time. Our hope is that we can learn, so not only can we lessen the problems that ensue from that disaster, but we can do a much better job in responding to future disasters.
How do we think about creating this essentially a springboard from public health practice into the capability to do research? And if we go that direction, if we identify certain questions that, hey, we should get this information, who can do it, and what are our assets to actually do it?
The real important piece for us is to identify people where any of those places are early on an ongoing basis, but to then be able to track those in a meaningful way, an objective way, but also in a way that's going to allow you to actually have some interventions that are going to help you with whatever the activities in the future. I do think that it cannot be underestimated the importance of collaborating with the city and county and state health departments. I think for companies to understand what capabilities exist by these other public health entities, not only will help us partner with them to meet the community need, but will also help us meet the needs of our own workforce.
Sometimes we could probably be used as a resource because we're out there the very first couple of days, and we can start seeing what the symptoms are. At least we can be given a questionnaire and, hey, what are you seeing out there? What's developing?
We're the responder that knows to capture that data, even if it's anecdotal, so that it's available when the research is available to start. Actually be very helpful.
Once an IRB protocol is approved, and normally that takes several months to do, IRBs tend to meet once every 2 weeks or once every 4 weeks, so we got to get on their schedule and then address their concerns, and then have different elements of the protocol approved, such as informed consent forms and things like that. And sometimes we're not able to pull all of that together at one time.
It's been really exciting to see, I guess, public health be at the table. And I feel like that's been a mission for all of us, is to figure out how we fit into the bigger response.
The Disaster Research Response Project, or DR2 as we like to talk about it, is a really exciting effort to deal with the fact that disasters and emergencies are not something that are going to go away forever. We're always going to have certain disasters, and we need to know how better to respond to them.
It would be very important for academic researchers to work with those public health entities who are conducting the surveillance, to be able to build upon those initial findings, perhaps to get to a root cause of particular symptoms. So to identify particular environmental exposures, for instance, that might manifest in a symptom that was identified by surveillance. So in that instance, research would be doing for surveillance what surveillance cannot do for itself. And again, for us to feed that back to the community, our stakeholders and community groups can do for us what we cannot do for ourselves.
I hope in the future that disaster research can be integrated with public health practice, so that when we respond and start doing an assessment or doing an evaluation of a community that's been hit by disaster, that we can pretty seamlessly bring on to follow that some good research that goes longer term and can help us understand better the overall impact of a disaster on a community and how to prepare other communities for similar disasters later.
So that was a summary of a workshop that we held in Houston in 2015, simulating a hurricane that came up the Galveston Ship Channel and caused massive damage to the city of Houston, which is a third largest city in the United States. Ironically, in 2017, exactly that scenario happened. Hurricane Harvey, it was a Category 4 hurricane that struck Houston, Texas in August 2017. It caused over $180 billion of damage in the U.S., over 130 deaths, over 200,000 homes were damaged and 9,000 homes destroyed, and caused catastrophic flooding in the city and surrounding towns, and also in industrial facilities. You can see these before-after pictures of Houston, downtown Houston, and how extensive the flooding is. And here's a map of Harris County, which is the county that Houston, the city of Houston, is located in. And you can see these red circles and diamonds and triangles are locations of flooded Superfund sites, flooded municipal waste sites, flooded petroleum storage tanks. And so all of these were then mixed in with the floodwaters and dispersed to wherever was inundated. So homes, businesses, communities now all of a sudden were flooded with these the mixture of waste and whatnot. Let's see. So the DR2 program supported the Hurricane Harvey efforts to try to provide a platform to engage the different resources and agencies, identify these different research gaps, try to share information and tracking with GIS tools to provide a common operating picture of what's going on, and then really springboarded the DR2 resources and training materials and the protocols that they had practiced on, and then built on with these different collaborations across the local, the state, the county, the state, and federal collaborators working together, and then providing some pilot funding, and then also working with these other interdepartmental agencies like the Centers for Disease Control, the National Science Foundation, USGS, FEMA, to provide some funding for researchers. The efforts were that Hurricane Harvey research efforts were able to get started. Like, remember the Gulf study and others, didn't start for 11 months after the fact. Folks were on the ground within 2 weeks. Actually, some investigators were actually on the ground in the midst of the floodwaters, collecting environmental sample data before before responders were even deployed into the cleanup efforts. They were there embedded with the first responders, and they're able to leverage these pre-existing relationships that they formed from the workshop two years prior to partner with the different health agencies and to try to collect valuable information that the incident command posts were able to use to identify any potential microbial contamination, any chemicals and heavy metals in the soils, testing of the sediments. You can see that there's a large number of collaborators that had participated, but then also conducting health studies of different surveys in the communities and the workers themselves to try to identify those that were impacted, and then try to map this all out and do the data management that is required for research purposes. So outcomes and lessons learned, and this was just published in the American Journal of Public Health last month, that these multi-stakeholder networks research can be fast and effective. Like, we can get out there, but it really requires doing the necessary work and relationships prior to when a disaster strikes. But if it works, we can be out on the ground and working with communities and providing this necessary information and the data that can be provided to the key decision makers at the time of the event, and then be able to use this information to come back afterwards to help in the recovery efforts and beyond. And so, as I mentioned earlier, that we worked with the University of Arizona early this year on a scenario that they were interested in, which was a train derailment that was carrying a car carrying flammable propane, exploded and then damaged cars that were containing industrial chemicals like chlorine and malathion in the heart of in the city of Tucson. So they worked through a scenario where over 6,000 people were evacuated, over 32,000 individuals within 2 miles were impacted, and then kind of walk through those different scenarios. And so here's just an example of what a GIS map of the location of hypothetical location and running through this tabletop exercise that they worked through. with the key goal of trying to identify the populations that were impacted, what the clinical and healthcare system would need for treatment and then efficacy of these treatments, and then trying to integrate the healthcare providers and what their concerns are with the academic groups and the responder groups to see what they're most concerned about to move forward. And so this was really locally led and really a broad coalition of partners across the group, and there was over I think Canadian DR2 program was involved, and so was Japan as well to learn from these exercises. And then ultimately they worked through some of these capacity. What are the capabilities within their each organization? What are the priorities? And just getting people to talk to around a common scenario so that you can identify these needs, these gaps, and then opportunities to kind of moving forward so that we can better protect the public health, both at the time of the response, but then also in the recovery, and then what the roles are. And so moving from data to public health practice to research, and focusing on the continuum of needs that each individual group has in terms of both acute and emergency management, so immediate life and safety, and then down to the healthcare providers, what they're looking for in terms of safety and effectiveness of their treatment modalities, to community health and environmental impacts and what they're most concerned about moving forward. So disasters are the whole iceberg. It's not just the response. Once the firefighters and the police and first responders pack up, the recovery can take weeks, months, years. They may never recover. And so how do we, as public health practitioners and best inform these things so that you can address policies and procedures that can be in place to help individuals recover fully. And there's a lot of IRB issues that need to be worked out, ethical considerations, looking at First Nations and things like that, training materials that are needed. And so there's a lot of work that needs to be done to kind of get everyone into the same page. So at least think about my research that may do X, Y, and Z, and they may not be able to see the links. But then when they kind of step back and say, oh, this is just to provide information to these decision makers, it helps and then facilitate, because the worst time to make these introductions is not in the midst of a disaster response. It is now, preparing for the event that we know, fire season is going to occur in these months. The time to prepare is now, not in the middle of June when fire season is the highest risk. In Arizona, we had these mock institutional review board sessions that we trained the IRB members on the different tools and collection procedures, what we would do, so they were comfortable with the process in terms of what and what would occur, so that when these scenarios should occur, then they're able to kind of move forward with these reviews. So the University of Arizona, took a multidisciplinary approach. They involved a whole host of poison control centers, population health and epidemiologists, toxicologists, pharmacy. They involved students, community members, and brought everyone together into the same room to kind of talk about their concerns, what each individual, and oftentimes, me as an epidemiologist may not be thinking of the same thing as a toxicologist would be thinking, as an exposure modeler, as a poison control center personnel or first responder. And so it's nice to kind of, make those introductions and get people onto the same page so that they can move forward and ultimately to try to protect public health. And so this is just a kind of some screenshots of what they were able to create. So they are looking at person, place, and time. Who are you? Where were you? Do you have any baseline? Just a very basic health survey, and then you can collect information on these first responders. And all this is available on the DR2 website. And so it's all integrated into an electronic data collection platform that you could use. It's available for free, and then able to map these things into a GIS to identify, and then also quickly be able to summarize these responses so that you can provide this information to first responders, to the public health community, medical community, that there's a huge prevalence symptoms of coughing and fast. So if people show up to your clinic with these symptoms, they may be, you should ask about potential exposures, and then here provide them this information in terms of mitigating exposures down the line. So the DR2 Center really is a network, and we're trying to engage and elevate the NIEHS grantee community. We're thinking that we're trying to embed these in with our environmental health core centers that are located throughout the United States, and get people to start talking to each other, talking about their capabilities, what their expertise is, and each individual center is focused on a different topic, but they are still able to provide some basic data collection needs that would be required, and oftentimes just getting people to just start thinking about what they can do collectively that they're able to provide to protect the public health. So that's all I try to rush through so that at least plenty of time for questions. But a lot of the information is available on the DR2 Program website that you can see here, and then also my email if you have any questions that come up later on. So thank you for your time. Sorry for all the technical difficulties in terms of getting everything set up. So appreciate your patience. Thank you.
So perhaps we could start with people in the room here if there's any question, and then we could go online. Tina at the NCCH, I think you are monitoring the chat portion of the GoToMeeting. So if after you've gone over the question here, I'll turn it over to you to perhaps skim through some of the question for Dr. Kwok. So any question in the room here?
Thanks for a great talk. So disasters are the whole iceberg, and we see a lot of funding quickly mobilized for the visible part of the iceberg. I'm wondering about in the the months and years that follow after the acute emergency crisis period has passed. Are there similar mechanisms to be tapped into to continue follow-ups with these groups, or is this really through individual research groups applying for funding to do studies?
In the U.S., we tried to use the model for these environmental health core centers to provide pilot funding, and so that kind of like bridges the gap for the acute needs, and then using that information then to provide longer term funding through the standard NIH research mechanisms, the R21, the R01 models, and so then it ties into the standard NIH grant funding cycles and whatnot. But collecting that critical information at the time of the spill or at the time of the event then provides the needed background information, because oftentimes you miss that opportunity and there's no other way to collect that information after the fact. But then that information is then valuable to inform these longer term studies that obviously then are surrounding research questions that would have to go through the standard reviews, but oftentimes that takes months to years, and you've missed the chance to collect that baseline data. And so this is an opportunity to try to collect that baseline data and provide a bridge to get to that longer term funding. Yeah.
So under this IRB that you were talking about, are you planning to do some questionnaires like for baseline data collection right away, right now? Like for questionnaires as well as like, samples like, urine or blood samples, like collection, just to keep on building this historical data set of baseline data so that it can be used in future events like?
So we're not planning just to do a baseline data collection of the entire U.S. population. I mean, there are existing studies out there that are focused around research questions, looking at environments like the All of Us cohorts that are started up. but we are interested in trying to introduce these concepts to the IRBs in terms of protocols for biospecimen collection, protocols for just basic demographic collection, and then be able to implement that quickly to deploy, so that while you may not be able to have baseline for months in advance, that you're able to then to link together at the time of the spill. Now that said, using Hurricane Harvey as an example, the research groups had the workshop in 2015. In 2017, Hurricane Harvey hit, and they were able to deploy into these communities and collect information. Ironically, just a month ago, Tropical Storm Imelda hit Houston and flooded them again. And so the exact same communities that were impacted in Hurricane Harvey also got flooded again from Tropical Storm Imelda. And now, but since they had done the studies 2 years prior, they said, wow, we have baseline data from 2 years prior during Hurricane Harvey. Let's go back into these community groups again and see, how they recovered, looking at the mental health, looking at allostatic load on these individuals, and repeated traumas over time. Can we see that, are these individuals being impacted repeatedly? What is their mental state? Do we need to provide additional resources in terms of from a public health perspective to be on the lookout for these things? So there's our opportunities, especially if you do the initial data collection, then to follow up later on, because you have a baseline that may be more than just a few days, because you've looked at that population prior.
Perhaps a last question from the audience here, and then we could turn it over to the NCCH and Tina for people on the line. There's two more questions. Well, let's go for two more questions. Even more so that I work with these guys. So,
I was just curious to know how this type of research is received if you go in on the ground, sort of close in time to when the disaster has struck. Is it well received by the victims, by the first responders?
Yeah, so a lot of it's, I think the worst thing that you could do is parachute into the community and say, I'm from the federal government, I'm here to help, and so it really hinges on your relationships with the local communities, and so that's why we're leading heavily on the academic groups to have these established relationships beforehand, so they have a trusted local community partner that will facilitate and understand what your needs are going in. And so oftentimes if you have these local partners, community groups partnering with you, they provide some additional verification and trust that then you can go in. Because oftentimes when you're coming in, I think we heard repeatedly in the Gulf communities that you're just going to parachute in, come collect the data, leave, and we'll never hear from you again. What are you going to do for us in these local communities? And so, establishing that trust, establishing that, this is why we're doing this, why we're collecting the data, having those conversations beforehand so that they understand what your needs are, and then ultimately how this then ultimately affects their communities, because you're providing this critical information that then can be used by key decision makers to deploy resources, to deploy programs that can then help address those needs down the road. So, but it requires doing the homework and the hard work in advance, because, you can't just come into a community and expect participation, even, regardless of who you are.
Danny Sokolowski, Health Canada. Many thanks, Dr. Kwok, for your very enlightening and comprehensive presentation. As you know, Canada is also trying to mimic in a certain capacity the DR2 model in the US. And we've, over the last 2 years, have started trying to develop a framework for better integrating research during disaster response here in this country. Obviously, the US has been at this much longer than we have, and we're probably with a substantial amount of resources, much greater than we have invested. You've obviously improved your ability to respond to these disasters in a tremendous way, going from Deepwater Horizon and the research that was conducted 11 months into following the disaster, compared to the Hurricane Harvey disaster that was, had researchers on the ground within a couple of days or 2 weeks from the disaster. Moving forward, can you identify the 2 or 3 greatest challenges that currently exist in trying to deliver or pursue the DR2 program in the U.S.? That may be a loaded question.
It's loaded. There's a long list of things, but it's funding is a big issue in terms of everyone is resource constrained, and so how can we best adapt what's there now to because we don't know when or where the next disaster strike or what the extent of it, but we know it will happen, and so it's getting into a preparedness mindset, but then getting that training in place so that these children environmental health centers are normally looking at pregnant women and babies. Can they respond if there is a rail disaster? And maybe still looking at pregnant women and infants, but then using an exposure scenario of the chlorine and malathion versus pesticides. Actually, malathion is pesticide, but shifting gears in terms of the different exposures, and a lot of it just getting people to talk to each other. And so a lot of people are very busy with their own research agendas and their own lives as it is, and so getting them to think about disasters or just getting to think about this context is difficult. But then when you sell it as an information gathering exercise, not research per se, because the first responders are like, I'm not a researcher, I don't do research, that's not part of our mandate. We don't understand how it fits in. It's part of the education process of getting them into the room and saying, oh no, this is information, key information that you need that you're already collecting, or you're collecting parts of it, or you're not collecting, in such a fashion that can then be used to inform future events. So you're just bound to keep repeating the same mistakes over and over just because it's historically what's been done, but not in advance in terms of what the science says, so that they could be smarter in terms of their deployment of the resources, and deployment of the limited resources that are available to better address and better protect public health.
Okay, Tina from the NCCH. I know we're running out of time, but since we started a bit late, it would be very useful to entertain some question you might have from the chat room. So I'll turn it over to you, Tina, if you have any questions. If we're still online.
Tina, are you there? Can you hear me, Mark?
Yes, we can hear you
Okay.
loud and clear.
So I don't know, maybe Tina got cut off, but maybe we'll just start at the bottom of the questions here.
Oh, yeah,
Sarah in the chat is asking, in the Deepwater Horizon disaster, what sampling was completed on seafood to ensure safety for consumption? What contaminants specifically were ongoing samples taken to determine ongoing exposure? Great question.
Yeah. So we worked with the the FDA, the Food and Drug Administration, to look at seafood exposures, and also the National Oceanographic and Atmospheric Administration, NOAA, to study seafood exposures and look at both shellfish and finfish during the Deepwater Horizon. So there was a lot of sampling done. They took catches from the fishermen as they were coming back ashore, and recorded where they had fished and tested the seafood to make sure it was safe from VOC exposures and also heavy metals. And so when it was determined that the fish was safe to eat, then they opened up those zones again. But for a while there, they closed off the entire Gulf of Mexico to commercial fishing. Now that's not to say that people didn't fish then and didn't consume that fish, because we know that people they're subsistence fishermen that fed things to their families and friends. So that obviously that is a concern. But we weren't able to test some of those finfish and the shellfish that were exposed.
Thank you for answering that, Richard. We actually had quite a few seafood safety concerns during the Bella Bella incident that happened a couple of years ago on the West Coast. Mark, could I ask you just to quickly flip back to the beginning slide for the NCC, if that's possible? And if I could ask for just one more question if we have time. There's one from Gordon that has to do with international borders. So have you already, or do you plan to collaborate with Canadian officials toward addressing any disasters that occur along our border? For example, smoke from forest fires that doesn't stop at jurisdictional boundaries.
Is that question? Yeah. So I mean, yeah, we certainly have a memorandum. We're currently setting up a memorandum of understanding with the Health Canada to provide technical assistance when called upon. So so certainly we are available to help if needed, especially these cross-border situations. I don't want to commit definitely, but that's definitely where we're capable.
Yeah, and I believe, Richard, you're planning on an upcoming exercise to occur in Seattle, right? So,
yeah, so we're going to be holding our next DR2 Workshop event in Seattle, Washington in January, I think, of 2021, and it's going to be an earthquake scenario that the folks in the University of Washington are interested in. So maybe the folks in Vancouver may want to pop down and still be involved. A lot of the concerns in that will be brought up at that workshop, may be common with folks in Canada as well.
So, Richard, if anybody is interested in participating in something like that, is it possible to forward me contact information at the NCCH, and then we can help connect people if they wish?
Yeah, of course.
That would be great. This is Angela, by the way. So just before we wrap up, I do want to point out to people that if you don't know the NCCH already, we are a Public Health Agency of Canada funded knowledge translation center, and our whole reason for being is to help support evidence-informed policy and practice. And you can visit us at the website shown on the screen, where we have many, many tools available for you, including, as we were discussing, kind of a mini repository of emergency response and recovery tools that focus on the Canadian context. So please do come and visit us and join our mailing list if you're interested. So Mark, back to you.
Okay, thank you so much, Angela. I think we're going to close the webinar. Once again, thank you very much, Dr. Kwok, for a most interesting seminar, and thank you everyone attending here physically and people on the line, and thank you NCCH for allowing to broadcast this most interesting seminar across Canada. So thank you again. Thank you.